Hey there, everybody. Welcome back to the Primary Care Podcast. It's your boy, Dr. Mark List, coming at you with another episode today. But before we get into it, obviously, we always start with messages, jokes from the Primary Care Podcast, primarycarepod@gmail.com inbox. Whew, it's been a rough morning so far. Let me just tell you what. Primarycarepod@gmail.com inbox. That's where you can send me jokes or questions or comments, fan feedback. I had a patient actually email me the other day. Not a patient, sorry. A listener email me. Whew, this is going to be a rough episode. I apologize in advance, guys. I had a listener email me and ask me, hey, Dr. List, have you ever do you ever use your dad jokes with patients? And yeah, I do. I try and keep my practice lighthearted. But there was really one specific example that stands out in my mind. One time I was in residency. I was up on labor and delivery. There was a woman in labor, and I was trying to lighten the mood, trying to diffuse a tense situation. And so I made a joke, and she just glared at me, and was not having it at all. And maybe it was just my delivery. All right, let's start the podcast.
The Primary Care Podcast is written and edited by a family physician for an audience of other physicians, nurse practitioners, physician assistants, residents, and medical students interested in primary care topics. This is not a podcast for patients and should not be used as medical advice. This is also a personal podcast produced on my own time and solely reflecting my personal opinions. Statements of this podcast do not reflect the views or policies of my employer, past or present, or any other organization with which I may be affiliated.
Thank you for listening to the Primary Care Podcast. I'm Dr. Mark List, here to bring you the latest news, guidelines, and updates from primary care sources around the globe. Keeping it under 15 minutes long because you're in a hurry and I'm not that smart. All right. Welcome back to the podcast. Pod girls, pod boys, pod people. It's your boy, Dr. Mark List. I'm actually recording this and that joke in clinic. We currently are under a winter storm watch. My first 3 patients all canceled for the morning, so I've just been sitting here. So I was like, hey, I'll just do a podcast episode while I wait for patients to show up. This podcast episode is actually in today's JAMA that I just got on my desk literally this morning. Read an article when I first got here, again, because my first patient no-showed, or actually canceled, shouldn't say no-show. And the article is not that awesome, but it's the effect of a diagnostic strategy using an elevated and age-adjusted D-dimer. So in patients where suspected pulmonary embolism, this was in Spain and France, and they had 1,500 patients or 1,400 patients came into the ER, and they standardized them, or they randomized them into standard care versus this intervention. And the intervention was basically they had to have a year's criteria. Okay, so year's criteria is basically they put them through this algorithm, and so then they said, okay, so if we have any suspicion of pulmonary embolism, we're going to put you through this year's criteria. Year's criteria basically was PE the most likely diagnosis, or did they have hemoptysis, or did they have, I forget the third one, hold on a second here, or did they have a clinical sign of a DVT, right? So those are the 3 years criteria. And if any of those years criteria were positive, then they went to an age-adjusted D-dimer status, okay? And so the math behind the age-adjusted D-dimer status is 10 times their age, okay? And if they had a negative years criteria, so PE was not the most likely diagnosis, there was no signs of clinical DVT, and there was no hemoptysis, then they used a high D-dimer threshold of 1,000 nanograms per milliliter, okay? Which is way, way, way higher than yours or my lab standard, right? And then if that was low, then they could exclude the PE based on that. If it was under that D-dimer setting, whatever that setting was, age-adjusted or that higher threshold, then they did not do any CT scanning, imaging. But if it was positive, then they did the CT scan. And the entire point of the study was that, right, D-dimers are pretty garbage, and they can be positive in lots of different clinical situations. So let's try and make them more useful by making age-appropriate ranges or putting a higher threshold to our D-dimer if we have a very low clinical suspicion of PE, right? And these patients that, well, why were we even suspecting PE in the first place? Well, they came in with shortness of breath, and they met some kind of criteria on the PERC rule, right? So PERC rule is the pulmonary embolism rule-out criteria. it's not easy to remember everything that's on that list because it's all vague, right? So if you want to make sure that you don't need to do any PE workup at all, ever, basically, if they're older than 50, doesn't matter. You have to think PEs in the differential. If they have a pulse greater than 100, again, you can't rule out a pulmonary embolism. If their O2 saturation is less than 94, you cannot rule it out without further testing. If they have unilateral leg swelling, hemoptysis, recent surgery or trauma, prior PE or DVT, or if they're using exogenous estrogen use, you cannot rule out a PE without further workup. Now, those are the people that they kind of put. You had to have one of those kind of triggers in order to kind of qualify for the study. Plus, shortness of breath or whatever your diagnostic case may be that brought you in. Syncope could be anything that could qualify you for the study. And then you had to go through this, either the standard control, which was basically like, okay, we're just going to test you with the D-dimer, and if you're positive, we're going to give you a CT scan. If you're negative, then we're not going to do a CT scan. And then in this control group, right, they tried to change the screening cutoffs for the D-dimer. So make the D-dimer more useful. Why? Because D-dimer has incredible rates of false positivity. Again, it can be up for lots of different reasons. It's not a very accurate test. And the whole idea is, can we not use so many CT scans? Can we stop doing all these crazy expensive and invasive PE workups and give people radiation on the CT scans? And yet, can we not miss PEs? Can we not miss hospitalizations? Can we prevent death, disease, and bad stuff while harming the patient less with our diagnostic workups, right? That's the entire point of the study. And in this study, using this, modified D-dimer process, so you change the D-dimer settings in terms of what's considered a positive D-dimer or negative D-dimer, either by using an age-adjusted if they're high risk, or using a high threshold D-dimer, right? Ignoring what your lab says is high and then putting your own threshold on it, okay? They were able to use 10% fewer CT scans, okay? So in the intervention group, in the main control group, right, anybody who had anything positive on their PERC score basically got a D-dimer, and they got basically 50% of those D-dimers were positive and needed a CT scan, 50% were negative and were ruled out at that point. In the entire study, in this intervention group where you use modified D-dimer ranges, only 40% of those D-dimers were then positive and needed a CT scan. 60% then did not need a further workup. Okay, so it decreased the CT scan use by 10%. So it's 10% fewer patients that didn't have to get a CT scan and get radiation. But my point is that at the end of the study, right, none of the other algorithms changed. None of the other outcomes changed, right? Death, future diagnoses of PEs at a later date, nothing else changed, even though we modified the D-dimer cutoff. So our standard positive D-dimer really doesn't really matter. We could use a higher D-dimer cutoff in this case because these people were lower risk based on this year score. My big take home from this point was that 7% of patients in this trial, right, presented to the ED with shortness of breath or syncope or some reason for suspected PE, right? These are 1,400 people in the ER who showed up to the ER because they thought something really bad was happening to them, and only 7% of these people ended up having a PE. The majority, 93%, had other things, right? But we as clinicians always worry about a PE when anybody comes in with shortness of breath or has any of these risk factors. And this gets back to that PERC score, right? The people were enrolled in this study because the PERC score was positive, right? So 93% of people that had something positive on the PERC score, either their age or their pulse or, exogenous estrogen use or, oxygen saturation less than 40%, basically had to have a workup for a PE, right? Because you can't miss a PE in there, in this scenario. But using even a modified D-dimer score, it didn't even change the outcomes, right? Only 7% of people total had a D-dimer, and only 1% were missed of all the PEs. 1% of that 7% were missed or delayed versus 0.1% in the control group were missed, right? So, and that wasn't statistically significant. There was no change in hospitalization. There was no change in mortality. Clinically significant data didn't change anything. And so that study is like, okay, great. So maybe we should use a modified D-dimer scale, right? But one of the more interesting editorials that I've ever read in JAMA about a study came attached to this, right? So in the editorial, this was page 2,135 for those of you who had this week's JAMA. Diagnostic Strategies for Suspected Pulmonary Embolism is the name of the editorial. And it's by Marcel Levi and Nick Van Ness, both MD PhDs. And, they talked through the study, and they basically, if you wanted to avoid reading the whole study and wanted to read their summary of it, it was really good. And then, right, they really summarized my feelings on how medicine is becoming very algorithmic. Okay, and you know me, right? I am in favor of doing less. Less is more. Study after study after study. We shortened courses of antibiotics recently. We do less surgical interventions. We do more physical therapy. We prescribe less medicine, and outcomes aren't that much different. And we talk about this probably every third or fourth episode on the podcast, that it's okay in a majority of cases to kind of use your clinical judgment and choose either not to intervene or intervene based on your clinical judgment. And in pulmonary embolism, that's really hard, right? Because pulmonary embolism is hard because a lot of patients have very few clinical symptoms. And the clinical symptoms that they do have are incredibly vague. And, that PERC score, a pulse greater than 100. Well, hell, how many of your patients have a pulse greater than 100, right? How many of your patients that come into the clinic or come into the ER are above the age of 50 that have shortness of breath? I mean, the differential diagnosis is massive. And yet, based on the PERC rule, which is supposed to help you basically, if all of these things are negative, then you can rule out PE. That PERC rule is really not helpful in most clinical scenarios, right? And again, in this case, this PERC rule, which is supposed to help you rule out pulmonary embolism, did not rule out pulmonary embolism in 93% of patients. And the CT scan yield that basically we're triggering based on a D-dimer, which is not that great of a test, right, is wrong in 93% of patients, right? 93% of people did not have a D-dimer. Oh, well, I guess that's half of the people had a positive D-dimer, and it's only 7% of those. So we're talking 43% of all the enrolled patients were harmed by a D-dimer, not benefited from the D-dimer, right? But I mean, this is what the problem is with pulmonary embolism and kind of trying to practice algorithmic-based medicine. And so this editorial, I'm going to read the editorial because I think that they did a really good job, and I'm not going to be able to summarize this as well as they did. Several factors should be considered interpretation of the study findings. Although the algorithms in this study were not particularly complex, the multi-step process presented in this trial could complicate the approach for evaluating suspected PE by very busy emergency department physicians. And you in the clinic are oftentimes, I've been in this situation too. I know you have in your clinic as well. Obviously, these were people who presented to the ER with shortness of breath or some kind of syncopal episode or something, right? But in the clinic, we also get these vague things as well, right? So include yourself in this if you're not, and maybe some of you are seeing these people in the ER as well. So this complicates the approach of evaluating suspected PEs by busy ER physicians who evaluate and treat patients with myriad clinical conditions. A diagnostic sequence that first requires you to calculate the PERC rule in patients and then apply other scoring systems, in this case, the years criteria, in PERC positive patients who judged to be intermediate risk, and then combine that with the D-dimer testing using a new differential threshold, it might not be the most practical or easy to remember approach in a busy clinical setting. Yeah, how many of you off the top of your head can name everything in the PERC rule? Not very many of us. Probably 0% of us. Well, I shouldn't say 0% of us because I'm a nerd and I memorize these things. But probably less than 5% of practicing clinicians memorize the PERC rule or even remember in a busy clinical practice to go look at the PERC rule, while you're trying to see, 20, 30 patients per day, or you're in the ER and you're stuffed to the gills with patients and you've got 5, 6 people in, you have a new trauma coming in, you have a chest pain, heart attack rule out, somebody's coding, and yet you have to try to remember not only to do the PERC rule, but then if the PERC is positive for anything, which by the way, the PERC is going to be positive for 90% of people coming in the ER because it has such vague diagnostic criteria, you're going to have to do this years approach and then have to remember this modified D-dimer threshold, right? How many of us are actually going to be able to do that? So then they go on to say, moreover, the proposed approach was only studying a cohort of patients with subjectively low or intermediate risk of pulmonary embolism. Why? Because if you're highly suspicious, you're just going to get the CT scan anyways, okay? And this also explains the rather low pulmonary embolism prevalence of only about 7% in the study. the safety of these diagnostic workups for a group with a higher prior suspicion of pulmonary embolism was not validated in the study, and the subtlety may not be easily forgotten. And this subtlety may easily be forgotten in clinical routine practice, as we're so busy in trying to remember all these rules. It could be argued that in clinical emergency medicine practice, a simpler approach might be preferred to avoid confusion or even possible errors. In addition, this doesn't apply to everybody, and they might have other symptoms of chest pain or shortness of breath or feeling unwell, and that sometimes CTs are useful in the ER for reasons that aren't even associated with pulmonary embolism, right? To establish an alternative diagnosis. So if we're saving the patient, 10% of CT scans, is that even a good thing in the ER and clinical medicine? Because then we're finding the diagnostic reason in those other times. So one of the reasons why I wanted to bring up this study was that I've been reading a lot more about PEs lately, and PEs just in general suck, right? It just is miserable because we're relying on tools. The CT scan is amazing, right? It has incredible diagnostic accuracy, but then we're relying on this garbage D-dimer test, and it depends on where you are. This can be a send-out test that takes time to come back. If you're in the ER, you're waiting hours just for the D-dimer test when you've got a CT scan ready and ready to go. Do you even get the D-dimer if you're suspicious? Nah, you probably just skip to the CT scan. And you and I, in outpatient or inpatient or emergency medicine clinical practice, are being bombarded and bombarded and bombarded by new algorithms and more increasing complex algorithms that are quote unquote changing the standard of care because these algorithms have been verified in the medical literature. But when it comes to having a busy practice, are you really going to remember to go through 2 different scores on this patient with PE? Are you going to really do the perk first, and then if that's positive, then you're going to go onto this year's criteria, and then you're going to have to remember a modified D-dimer, and then you're going to have right? It's going to become, at least at some point, overwhelming. You're going to make mistakes unless you're kind of constantly using up-to-date or refreshing and reviewing these articles, right? Versus just using clinical medicine, right? Do you suspect they have a D-dimer, or do you expect they have a PE? Then get the CT scan or get the D-dimer and not have to worry about these criteria, right? At some point, I talk about clinical suspicion, clinical awareness, a clinical gestalt, right? Having some true value when it comes to clinical medicine and not harming patients with excessive testing, right? And excessive workups. And again, in this study, even in a high-risk situation like the ER, even in patients who have a positive PERC score, right, only 7% have a PE. And at some point, are we losing our clinical judgment, relying on algorithms and algorithms and algorithms to help us guide what tests we even order? Not even what things we diagnose or what medications we use, but what tests we're ordering, what our clinical suspicion should even be, right? And I know everyone wants to fix PEs and everyone wants to find every single PE, and that should be the goal, right? That should be the goal, so that no PE is missed. And yet we are then harming, 90% of patients that get a CT scan end up having no diagnostic yield for PE, even despite the clinical importance that was listed in the study. Under multiple studies have found that to be the case, where 90% of our CT scans for PE diagnoses do not find a PE. So 90% of patients are kind of quote unquote harmed by that in terms of their workup not showing any clinical significance. So again, to wrap up, this is a good study. It tells us that the D-dimer is not very useful in a clinical practice, and you can even modify your D-dimer thresholds if patients meet certain criteria. But I think my big take-home from the study is the fact that, here's a study that uses multiple algorithms, multiple changes to structures, and the outcomes aren't any different. Yeah, we use 10% less CT scans, and your ER trips were like an hour shorter because you didn't have to have the CT scan and more workup to rule things out. But at the cost of physician well-being, burnout, feeling overwhelmed by trying to memorize all these diagnostic algorithms, right? So again, hopefully this was a helpful, at least, refresher of PE algorithms, that PERC score. Maybe you now learn something about D-dimer thresholds or age-adjusted thresholds that probably don't matter in terms of clinical practice compared to your normal lab cutoff for D-dimers. The fact that, older patients are going to have positive D-dimers at a higher rate, and so you can have an age-adjusted cutoff is always valuable to remember. But ultimately, I think my take-home is, at some point, yes, there are algorithms out there to help you when you're struggling, but as the editorial says, we're starting to be on that threshold of kind of overwhelming practitioners with algorithms and diagnostic aids that are no longer aiding us, and they're now getting in the way, and they're creating more and more busy work for us to do during busy clinical practice. So anyways, hopefully this was at least a helpful study for you, or at least a helpful refresher on PEs. I find it just interesting and fascinating to read about maybe the cons of following algorithms and trying to be more, have more rules and guidelines. That sometimes it is harmful, and sometimes it's overbearing, and sometimes there's a downside to all these things with evidence-based medicine. It's not always rainbows and butterflies. Evidence-based medicine sometimes can go too far, and clinical judgment can be still a very useful tool in our toolbox. So anyways, I still don't have a patient in practice yet. It is now snowing harder and harder as I look out my window. I don't know how many of my patients are going to cancel today. Maybe it'll be a slow clinic day. But hopefully this was helpful. I will see you next week. Reminder, you don't need to stay up all night to stay up to date. Thanks and have a great week. Bye.